Hello, and welcome to Harm Reduction, Medications for Opioid Use Disorder, and Pharmacists. My name is Amy Werremeyer, and I'm a PharmD and board-certified psychiatric pharmacist, and associate professor and chair in the Department of Pharmacy Practice within the School of Pharmacy at North Dakota State University. As a part of my position, I have regularly practiced for over 14 years in psychiatry settings as well as substance use disorder treatment settings, so I'll be drawing from some of that experience as we go through today's discussion. At the completion of this presentation, the attendee should be able to define medications for opioid use disorder, which was formerly referred to as medication-assisted treatment, and we'll be going through the reasoning for that adjustment to terminology, as well as defining harm reduction. The attendee should be able to identify examples and standards of care and medications for opioid use disorder and harm reduction practices, to identify harm reduction challenges and resources, and list ways that pharmacists can participate in medication for opioid use disorder practice and harm reduction practice. Let's start off with some baseline information and facts so that we're all on the same page in approaching this discussion. In America in the past year, about 53.2 million people used illicit drugs. This is about 19.4% of the US population and equates to almost 1 in 5 people aged 12 years and older. In addition, about 10.3 million people used opioids extramedically, which means that they were used outside of their prescribed purpose or were used illicitly. 7 million people injected drugs. I'll be referring to this group as people who injected drugs or people who inject drugs, and using the abbreviation PWID to refer to this demographic. Of these, 30 to 40% will die within an 8-year period. Substance use disorder is a chronic, relapsing, treatable brain disease. Substance use disorder is not a moral failing, not a result of low willpower, and not a lost cause. But it is a chronic, relapsing, treatable brain disease. So we'll be approaching this discussion from that framework. Results from the 2018 National Survey on Drug Use and Health allows us to look at illicit drug use in a little more detail. We can see that marijuana leads the pack, followed by 2 different extramedical uses of prescription medications. Hallucinogens come next, and that includes a broad array of possible substances, including LSD, PCP, peyote, mescaline, psilocybin mushrooms, ecstasy, also referred to as MDMA or Molly, ketamine, and others. Cocaine, prescription stimulant misuse, inhalants, methamphetamine, and heroin round out the remainder of the medications or substances used. In the previous slide, we saw that 7 million of the 53.2 million who used illicit drugs in the United States injected them. So what are they injecting? Those noted to be extramedically administered by injection, sometimes or all of the time, include prescription pain relievers, prescription tranquilizers or sedatives, hallucinogens, cocaine, methamphetamine, and heroin. I've called your attention specifically to drugs that are often or sometimes used by injection because of the significant health-related consequences that are possible when drugs are injected. The first of those is overdose. Those of you who have participated in 1Rx have been trained to screen patients, especially those taking opioids, for overdose risk, whether that be because of extramedical use of them or because of accidental or unintentional circumstances leading to increased risk, like concomitant disease states, concomitant medications, etc. Those of you who have participated in 1Rx have also been trained to prescribe naloxone with the goal of preventing fatality from overdose related to an opioid. So as pharmacists, many of us are equipped and ready to help with prevention of the #1 consequence of injection drug use. The next most important consequence of injection drug use is infection, including infection with pathogens, including hepatitis C, HIV, hepatitis B, and a host of additional bacterial-related problems. Sharing needles or syringes is the main risk factor for new hepatitis C virus infections and remains an important risk for new HIV infection. Acute HCV infections in the US more than tripled over a 10-year period to a total of 2,967 new cases in 2016. During that same time period, rates of injecting as a method of drug use nearly doubled. The two are very closely related, such that 69% of people who inject drugs had acute HCV infection in 2016. And people who inject drugs represent about 9% of new cases of HIV in the US. In addition to injection itself, sharing drug preparation containers, filters, rinse water, and backloading, a method of sharing drugs by transferring them from the needle of one syringe into the barrel of another, increases the risk of HCV acquisition. In addition to the potentially lifelong or long-term problems associated with acquiring hepatitis C or HIV in association with injection drug use, there are additional infectious consequences that can occur. Injection of contaminated drugs or use of non-sterile techniques can also lead to problems like cellulitis, the development of abscesses, bacteremia, endocarditis, osteomyelitis, sclerosed veins, and peripheral edema. The good news is that all of these consequences, those from the previous slide and the ones you're currently looking at, can be prevented or at least minimized, and disease transmission can be reduced or completely eliminated. The two most proven methods of infectious disease prevention associated with injection drug use include access to medications for opioid use disorder and availability of sterile syringes. We're going to be talking about these and other approaches to reducing the consequences of injection drug use going forward. On the previous slide, we saw that access to medications for opioid use disorder and access to sterile syringes were the two best known ways to prevent complications from injection drug use. So let's unpack these a little bit more. Medications for opioid use disorder, which was formerly, and in some cases still is, referred to as medication-assisted therapy, describes medications to treat substance use disorders, and these may or may not be combined with behavioral therapy. Medications for opioid use disorder is now preferred as terminology over the term medication-assisted therapy, because medication-assisted treatment or therapy is not really accurately reflective of the evidence and literature these days. Assisted in the terminology medication-assisted treatment implies that the bulk of the treatment is something else, and medications are an accessory that comes alongside it and isn't truly necessary. But that just isn't true. Much evidence indicates that medications change continued use, change morbidity, and change mortality outcomes for patients who use opioids, all by themselves. The medications for opioid use disorder have the ability to impact morbidity, mortality, and patterns of continued use, all by themselves. Counseling and behavioral approaches generally don't do that. They do help people engage in treatment, they help modify attitudes, they help increase life skills, etc. So it often is best to offer both counseling and medications, but neither one should be denied to someone who isn't willing to engage in one or the other, because they are both useful in their own ways, and the evidence base is very strong that medications for opioid use disorder are effective, even if counseling measures and therapies are not employed. Some providers or agencies still use the term medication-assisted therapy, like the Substance Abuse and Mental Health Services of America, and many will likely continue to do so, and that's fine. I just chose to use medications for opioid use disorder here in this presentation to help us emphasize the primary role of medications and how they can be used as monotherapy in successful treatment of opioid use disorder. And the reasons that medications for opioid use disorder can be so successful in changing morbidity and mortality numbers associated with opioid use are twofold. One, they block the euphoric effects of alcohol and opioids. so that when alcohol and opioids are used on top of a medication for opioid use disorder, the person will experience very few, if any, reinforcing properties of that additional substance, and therefore be less likely to continue to use it going forward. It just doesn't deliver the same kind of benefit that it previously would have. In addition, medications for opioid use disorder relieve physiological cravings and normalize body functions without the negative effects of the abused drug. So it's well established that after long-term opioid use, adaptations in the brain and body occur because of the long-term presence of the opioid drug. This leads to a new homeostasis, or a new body normal, that can't be rapidly undone. And that leads to the development of cravings and altered body functions that feel extraordinarily uncomfortable and often lead to reinitiation of opioid use in order to try to maintain or return that homeostasis, that new homeostasis feeling, to get back to that new homeostasis. So medications for opioid use disorder can help to relieve the physiological cravings that come about and help to return the body to that homeostatic status. But they can be administered in safe and standardized doses, so it reduces the chances of infectious complications and overdose that would be seen or would be possible when an illicit substance or extra medical use of an opioid are being used to try to achieve that new homeostasis again. Now, harm reduction is a public health approach to reduce disease impacts in communities associated with drug use. The central elements of harm reduction include acceptance that people who use drugs are entitled to basic human rights, and provision of practical, accessible policies and services aimed at reducing negative consequences associated with drug use. Essentially, harm reduction incorporates a spectrum of strategies from safer use to managed use to abstinence to meet drug users where they're at, addressing conditions of use along with the use itself. Naloxone, medications for opioid use disorder, and access to sterile syringes are all strategies that fit under the umbrella of harm reduction. Those of us without specific public health training or expertise may be more challenged in thinking about all the considerations surrounding mitigating the harms of drug use. We're used to thinking about individual patients and their individual treatment plans. So it can take time to grasp the benefit of supporting what we know are unhealthy behaviors for a better overall outcome for individuals and especially for communities. What we may not immediately grasp is that although harm reduction usually helps the individual being served, the purpose is largely one of improving population health on a relative scale by reducing harm among some members of that population. Some of those important considerations from the public health perspective include that, as we've already talked about, drug use and misuse continue to create public health challenges in the United States, leading to such problems as overdose deaths, HIV, and hepatitis C infections, among many others. But what we also might not think about or have not thought about yet is that substance misuse treatment is too often unavailable or unaffordable for the people who want or need it. This population is often alienated from social and medical institutions because of the stigma associated with their lives and circumstances. Negotiating the available publicly funded healthcare is challenging, and many are not successful doing so. And furthermore, drug treatment programs with policies that require complete abstinence and excuse people from treatment for continued drug use do not prevent disease, promote health, or prolong life for those people. Evidence shows that repeatedly. Think about it this way. Imagine if an internal medicine physician excused a patient from their clinic because they had a second heart attack, despite the physicians working with them in controlling their risk factors. It seems unthinkable that that would happen, but yet it happens in substance misuse treatment all the time, and it's often overlooked as just part of the way the treatment system works. But it doesn't have to be that way. It can be adjusted with policy change. An additional aspect and consideration from a public health perspective that we might not have thought of is that a criminal justice response, including requiring arrest to access health services, is ineffective, not associated with evidence showing benefit, and leads to other public health problems.
In the more than 40 years since President Richard Nixon declared a war on drugs in 1971, the United States has spent an estimated $1 trillion on policies pertaining to the war on drugs.
Yet national rates of drug use have remained relatively stable, albeit with some minor fluctuations up and down. Meanwhile, drug-related harms such as the spread of bloodborne diseases and accidental overdose deaths have grown severely worse. Overdose is second only to motor vehicle accidents as a leading cause of injury-related death in the United States. The domestic drug war has also been an engine of mass incarceration. With less than 5% of the world's population, but nearly 25% of its incarcerated population, the United States imprisons more people and at a higher rate than any other nation in the world, and that's largely as a result of the war on drugs. Our prisons are generally filled with individuals who are there because of drug use. Public funds are routinely prioritized for drug law enforcement instead of proven HIV or hepatitis C prevention strategies. While drug war budgets have generally increased, effective treatment programs are chronically undersourced, and in the United States, practically no federal funds are invested in programs that will reduce harms related to injection drug use, according to what the evidence base has shown. Public health approaches offer effective, evidence-based responses to drug use, but some of the most effective interventions are not currently allowed or implemented in the United States owing to outdated drug laws, attitudes, and stigma. These public health approaches are driven by the public health goals of preventing disease, promoting health and well-being, and prolonging life. The practical strategies and ideas employed by harm reduction to achieve these public health goals place the overall health, safety, and well-being of people who use drugs and society above the narrow and often elusive goal of abstinence. These public health approaches accept that a continuing level of drug use, both licit and illicit, in society is likely inevitable, and efforts to completely eliminate all drug use are likely futile. In addition, these public health approaches define objectives as reducing adverse consequences. They emphasize the measurement of health, social, and economic outcomes as opposed to measurement of simply drug consumption. The concept of medications for opioid use disorder, also commonly referred to as MAT or medication-assisted treatment, is one of those highly evidence-based public health responses to opioid use and misuse. Medications for opioid use disorder, we're going to use an opioid when we're employing this approach, but we're not going to use just any opioid. We want to use a drug with a very long half-life. This helps get patients off the roller coaster of drug use, of the highs associated with the intoxication with the substance, followed by very significant and dramatic crashes down into withdrawal. When a medication for opioid use disorder is being used, it relieves withdrawal and cravings. We now know that withdrawal is the absolute most significant contributor to ongoing use of drugs, especially opioids. And the medications used for opioid use disorder do not produce euphoria in tolerant patients, and in fact, they have the ability to block euphoria or euphoric effects from other opioids. Because of their high affinity for the opioid receptor, they're not going to allow other opioids that are introduced into the system to bind to the opioid receptor nearly as often. And since buprenorphine and methadone themselves do not produce euphoria, the overall experience of any euphoria from use of opioids is much, much lower when these medications are on board. And an additional key point about medications for opioid use disorder as a public health approach is that it involves use in a controlled setting. And this decreases the risks of diversion to others and dramatically decreases the risk of IV use of drugs because there's a continuous supply of the opioid available. The person no longer has to go looking for other ways to obtain opioids and will be less likely to feel the need to inject them because they have essentially a steady level of the opioid in their bloodstream, reducing the risk for seeking the substance in other ways and using it in other ways as well. And the vast majority of medications for opioid use disorder programs combine medication with counseling and other services. Although it's very important to note that the evidence base indicates that counseling and other services are not an absolute must-have, and medications for opioid use disorder should not be withheld in instances when counseling or other services are not available, because the evidence is so strong that medications for opioid use disorder reduce mortality all on their own. And again, that's one of the reasons why the shift away from terminology of medication-assisted treatment, implying that medication alone is not enough. It's not ideal, but it is much more effective than doing nothing. This image depicts a vicious cycle that may commonly occur with opioid use. Opioid use beginning at the top, especially that which has continued longer than a couple of weeks to a couple of months, typically leads to physical dependence. And physical dependence without the presence of the opioid on board, let's say, for example, the opioid is discontinued, or the person can no longer access a prescribed opioid that they had been receiving because of a prescriber decision, that may lead to withdrawal. It often does. If the person has developed physical dependence, then by definition, they will experience withdrawal upon discontinuation or even large dose reduction of the opioid. Withdrawal from opioids, though never fatal on its own, is extraordinarily uncomfortable and often leads to desperation, a desire and a strong seeking of an opioid to relieve the withdrawal symptoms because they're so incredibly uncomfortable. And this desperation then may lead to bad behavior, such as purchasing from non-medical sources or seeking to inject an opioid in order to get relief from the withdrawal symptoms as fast as possible. And including things like robbery in order to obtain money to purchase opioids, for example, would be another type of bad behavior that can occur in this vicious cycle of opioid use. So this circle goes round and round. The longer the person must rely on opioids from non-medical sources, from non-medical use of opioids, and we never know when the individual may exit off of this cycle, off this vicious cycle, into death as a result of opioid use. Because as we know, the larger amount of an opioid that is used, the greater the risk for overdose death from respiratory depression. But the vicious cycle does not have to continue round and round and round in the way it was depicted in the previous slide. When we implement medications for opioid use disorder, or MAT, into this circle, we are able to cross off the withdrawal square. Essentially, physical dependence will develop to a medication that is used for opioid use disorder, but we don't have to worry about the person experiencing withdrawal, at least not to the degree that they would if they were not using medications for opioid use disorder. So it breaks this cycle and drastically reduces the chances that the person will continue circling around this circle and exiting off into death. By providing a consistent, stable amount of opioid, we help to address that physical dependence, prevent withdrawal, and reduce drastically the likelihood that the person will experience desperation, perform behaviors that are inadvisable and criminal, for example, the less likely that they're going to continue to seek opioids from non-medical sources, and of course, much less likely that they're going to experience death from an overdose as a result. So let's talk a little bit more specifics about the medications used for opioid use disorder, or MAT. As the name implies, the medications are primarily used for opioid use disorders, and those can be any opioid use disorder involving any opioid substance. So the medications for opioid use disorder, or MAT, can be employed for individuals who are dependent on illicit opioids like heroin, on prescription opioids like morphine, fentanyl, oxycodone, etc. Works for any of those. So the first medication we'll talk about is buprenorphine. It is a mu receptor partial agonist. That means that it lands at the opioid receptor, but carries out somewhere around 50% of the full effect or full action that a full opioid agonist would. A full opioid agonist being something like morphine, heroin, fentanyl, etc. The typical opioids we tend to think of. So buprenorphine is going to act about 50% as potently at this receptor as morphine would. But remember, it's also going to block that receptor so that any other opioid that may come on board will not be able to attach to that receptor nearly as easily as it would have if buprenorphine were not in place. So this approximate 50% action at the receptor is enough to reduce withdrawal drastically, but it also is not enough to produce a lot of euphoria. In fact, there's virtually none when buprenorphine is being used. It also brings about very little constipation and very little drowsiness. Patients can generally expect reduction of their withdrawal symptoms and cravings over the long term when they're taking buprenorphine. If you remember, the goals of medications for opioid use disorder treatment are to block the euphoric effects of opioids, relieve physiological cravings, and normalize body functions without the negative effects of the abused drug. So buprenorphine ticks all of these boxes. It is important to keep in mind, though, that when starting buprenorphine, a patient actually does have to experience withdrawal, and then they start the buprenorphine therapy. And just to remind you, withdrawal symptoms associated with opioids tend to include things like restlessness, muscle and bone pain, which can be quite significant, insomnia, dilated pupils, diarrhea and vomiting, cold flashes with goosebumps, and sometimes some kicking movements accompanied by severe cravings. Buprenorphine is useful in drastically reducing all of these opioid-related withdrawal symptoms. It's also important to keep in mind that only providers who have gone through a specific training are allowed to provide buprenorphine, and those are indicated by an X addition to the DEA number. There has been debate about the duration of therapy with buprenorphine. Initially, the thought was that this medication should be used for somewhere around 30 days, or maybe out to 6 months. But unfortunately, that pattern of use has been associated with drastic increases in the rates of death when the buprenorphine therapy has been discontinued. We now have a much stronger understanding that opioid use disorder is a chronic, treatable, relapsing brain disorder. Therefore, lifelong therapy is likely the best route to go, as we would conceptualize any other chronic, treatable disease, such as hypertension or diabetes. We would never expect that providing antihypertensive therapy for 6 months would make hypertension go away. We know with that chronic condition, generally long-term therapy is going to be needed. Not for everyone. Sometimes people with hypertension can drastically reduce their weight and adjust their exercise habits and change their diet and reduce their need for antihypertensive therapy. And that same concept applies to opioid use disorder. Many people will need long-term therapy or they will experience a complete return to the illness symptoms. But some people, after a period of treatment, accompanied by changes in their lifestyle, changes in their socioeconomic circumstances, etc., they may be able to reduce or discontinue their therapy and not experience a relapse of their symptoms. So it's really helpful if we think about medication for opioid use disorder in that chronic disease, relapsing but treatable disease type of concept. A second medication that is used for opioid use disorder is naltrexone. This is not to be confused with naloxone. Though both naltrexone and naloxone are both mu receptor antagonists, blockers, they are pharmacokinetically quite different. Naloxone is often included in combination with buprenorphine, and in that instance it is used as a prevention for diversion of the buprenorphine product. Naloxone is completely inactive when it is ingested orally. So if the individual is taking their combination buprenorphine naloxone as prescribed, as in by mouth, then the naloxone part will have absolutely no effect whatsoever. It will pass right through their system without ever entering the bloodstream. However, if the individual crushes and injects the buprenorphine naloxone combination, naloxone will then be very active and act as an antagonist in the bloodstream, preventing euphoria and inducing withdrawal. Naltrexone, however, is orally active, and it is a much longer acting compound than naloxone is. It does not have any abuse or overdose potential because it's not able to act as an opioid would, and it doesn't produce any euphoria either. When patients are taking naltrexone as part of their opioid use disorder treatment regimen, they can expect a reduction in cravings, as well as some nausea as a side effect. But notice that we don't see that they will expect a reduction in withdrawal symptoms when taking naltrexone. That is not part of the treatment approach when naltrexone is used. It's not able to relieve withdrawal symptoms. In fact, it will induce withdrawal symptoms if the patient is opioid tolerant. There's a general recommendation that the patient should be free from opioids for 7 to 14 days prior to initiation of therapy with naltrexone in order to minimize the induction of more severe withdrawal symptoms if naltrexone is rapidly introduced when they are, for example, just discontinuing their opioid. Anyone can prescribe naltrexone. It does not require any specific training. And the duration of therapy with naltrexone is generally at least 6 months, although we would want to continue to apply the same concept as I talked about in the previous slide about opioid use disorder being a chronic, treatable, relapsing brain disorder. And thus, there is no need to limit the duration of therapy. As long as naltrexone is working and tolerated and affordable for the patient, and they want to continue it, there is no problem with that whatsoever. Naltrexone is also available in a long-acting injectable formulation in addition to its oral formulation. The long-acting injection is given once per month, and it is actually associated with improved outcomes over and above the oral form of naltrexone. Those improved outcomes being things like longer retention in treatment and a higher rate of having urine drug screens that are negative for any opioids. Naltrexone is probably best for highly motivated, perhaps already opioid-free patients who are experiencing cravings. Compared with buprenorphine, again, it's less likely to treat withdrawal. So if patients are struggling with severe withdrawal symptoms or protracted withdrawal symptoms, naltrexone is probably not as advantageous as buprenorphine or methadone, the next medication for opioid use disorder that we're going to talk about. The third medication for opioid use disorder that we'll talk about is methadone. Methadone is actually the gold standard of treatment for opioid use disorder and was what led to the advent of medication-assisted therapy as a concept. It is a full mu receptor agonist, similar to morphine, heroin, fentanyl, etc., the opioids we're used to hearing about. But it's different than those opioids because it has a very slow onset, leading to very little euphoria. It also has a very long half-life, which reduces the potential for any withdrawal that it may bring about. And because of its very slow onset and offset, it tends to have a lower degree of risk for a lot of the typical opioid type side effects we think about, such as constipation, drowsiness, and nausea. People who are already tolerant to opioids or become tolerant to methadone generally have very few side effects. But we do have to keep in mind that because of its full mu receptor agonism, methadone does carry risk for respiratory depression. When patients are taking methadone, they can expect relief of withdrawal symptoms and cravings. In fact, the dose of methadone is titrated to help suppress those withdrawal symptoms and cravings. Typically, a dose around 20 to 30 milligrams would be an initial dose of methadone when it's being used for opioid use disorder, and it would be adjusted to suppress those withdrawal symptoms and cravings. Methadone can be administered via a licensed opioid treatment program only. These are registered through the Substance Abuse and Mental Health Services of America. And there is a requirement that when methadone is being used for opioid use disorder, that the patient have daily observed doses for at least 90 days, followed by the potential for some take-home doses, but still some observation of doses on site as well over the following 2 years. As you probably are aware, methadone can be prescribed for pain outside of an opioid treatment program, but when it is being used to target opioid use disorder, it must be associated with a licensed opioid treatment program. And that has some issues with access to therapy. There are pockets of locations in the United States and around the country that do not have very good access to methadone treatment because of the low availability of these licensed opioid treatment programs. That has been improving in the last decade or so, but still not ideal at all. And that's one advantage of buprenorphine over methadone is it has a lot greater access because of the ability for it to be used outside of these specific licensed treatment programs. Similar to what we talked about with the other medications for opioid use disorder, the duration of therapy with methadone is probably best thought of as lifelong, or at least long-term, because of the fact that opioid use disorder is a chronic, treatable, relapsing brain disorder. We know that mortality rates rise 3 to 4 times when methadone is discontinued, and so long-term therapy with methadone is generally encouraged. Methadone has been shown to be more effective than the combination of buprenorphine and naloxone in retaining patients in treatment, and it's been equally effective as buprenorphine and naloxone combination in reducing illicit opioid use amongst patients that are taking it. So just to reiterate, here's a picture of the 3 options we talked about as medications for opioid use disorder. Note that the empty opioid receptor is depicted at the top of this image. And that's generally something that we want to avoid when we're treating someone with opioid use disorder. The empty opioid receptor, for one, can receive opioid medication that's brought in from outside, whether that's orally, through injection, through other techniques, etc. And that empty opioid receptor receiving opioid certainly is what we get concerned about and where the harms related to excess opioid use come in. In addition, empty opioid receptors tend to be associated with withdrawal symptoms and the development of cravings. So when we employ methadone, buprenorphine, and naltrexone, we do not end up with empty opioid receptors, at least not for very much of the time in a 24-hour period. Each of these medications occupies the opioid receptor in its own way. Methadone as a full agonist, generating a full effect of an opioid, buprenorphine as a partial agonist, generating limited effect of an opioid, and naltrexone as an antagonist, blocking the effect of any other opioids introduced into the system, but still occupying that receptor, likely reducing the experience of cravings. Any of these may be an ideal option for an individual patient, but the choice of which agent we may use really depends a lot on the patient's individual circumstances, their comorbid conditions, and the length and type of opioid use that they've been engaging in over time. Colleagues and other health professionals have raised important questions about medications for opioid use disorder, including things like, isn't it just replacing one substance for another? Isn't it just enabling the person's addiction? I don't want to be a part of helping someone be hooked on yet another drug. These are valid concerns, and I like to see that kind of critical thinking about any kind of treatment that we might implement. My response to these questions would be that as health professionals, we have a responsibility to look to the evidence to guide us and to provide evidence-based treatment to reduce suffering and harm. We all took oaths to that effect, in fact. In the case of medications for opioid use disorder, the data speak loud and clear. Statistics show us that untreated 10-year mortality for individuals with opioid use disorder is 30 to 40%. There really aren't very many other conditions with mortality rates like that. But implementation of methadone in the opioid use disorder treatment decreases mortality by about 70% over untreated controls. Somewhat similarly, buprenorphine decreases mortality by about 50% over untreated controls. Rates of overdose death in patients terminated from medication for opioid use disorder treatment programs more than double. So we know that medications for opioid use disorder save lives. And these are just the mortality data. I could spend the next hour showing you more data about reduced morbidity, reduced crime and incarceration, improved job maintenance and performance, decreased emergency department use, decreased hospitalization, and financial savings to the individual, to state governments, and to society in general. But I won't, because we don't have that kind of time, and because I hope the mortality data are enough to illustrate that if you support evidence-based care, then you support medications for opioid use disorder. There are many ways that the pharmacist can get involved in the provision of medications for opioid use disorder. The first is access. Simply by stocking buprenorphine, naltrexone, both oral and long-acting injectable formulations, naloxone, and possibly methadone, the pharmacist is promoting access to these medications. You might even consider letting providers in your area know that you stock these medications, and perhaps they will be able to direct their patients to you, knowing that you'll have these medications in stock and ready to support their patients. Of course, For outpatient or community pharmacies, stocking methadone is just fine, but it can't be used for opioid use disorder purposes, as we've previously discussed, only for pain. For hospitals, stocking methadone is applicable and can be used for the purpose of medication for opioid use disorder on an emergency basis, typically for a duration of 72 hours. We might even consider, if you work in a hospital, helping to ensure access to these medications for hospitalized patients and work with the treatment team at the transition to discharge, asking questions like, how will the patient get their buprenorphine and methadone upon discharge? Continuation of that care is really extremely important, as we'll touch on again in just a minute. The pharmacist can also get involved through education and promotion of adherence. These are absolutely huge. Many patients don't have much of an understanding of the ins and outs of this kind of therapy. Also, non-adherence with medications for opioid use disorder therapy is potentially fatal. After a period of stable use of either buprenorphine or methadone, or especially after a period of non-use, as in the case with naltrexone, there is a reset of the patient's tolerance level. They are no longer very tolerant to opioids at all. And that's even after a cessation period of a week or less. If they stop their medication for opioid use disorder therapy, cravings for opioid and withdrawal symptoms will likely ensue, which may lead to illicit use of an opioid. And the potential for fatal overdose at this point is very high because the tolerance to previous levels of opioid use is no longer there.
And the patient is very susceptible to the respiratory depression that an opioid could bring about. So I would suggest going beyond the don't drive after you take this, and this may cause constipation, counseling points when talking with your patients about medications for opioid use disorder. Talk to them and tell them this has the potential to save their life and to change the circumstances of their life if they will let it.
Give them hope. Medications for opioid use disorder literally can be an individual's ticket out of the mess they may find themselves in associated with their use disorder. Let them know about the dangers of the medication, including things like overdose risk, the importance of not combining it with other sedatives, the importance of not taking it and how that might impact them if they don't take it, and the importance of not taking it other than the way it's prescribed to them, because as we know, those can lead to serious issues and even death. So educating the patient about those concerns. And then ask them questions, not just, do you have any questions, but things like, how are you feeling about this therapy? Are you on board with it? What is your plan to take your medication regularly? Maybe you can even offer to sell them a pill minder. Ask them what their concerns are. Encourage them to share what they're thinking about the medication and how they're planning to fit it into their daily life. That's one of the most important things that can help to promote adherence and optimal outcomes of this kind of therapy. The next way that the pharmacist can be involved in providing medications for opioid use disorder is in collaboration with the entire treatment team. The most common and successful primary care models in providing medications for opioid use disorder were coordinated care models, which had at least two different types of healthcare professionals actively communicating and working together to share care responsibility. Most commonly, these have been nurse case managers or pharmacists plus a prescribing physician. A few examples of this type of collaboration would include observing methadone dosing, participating in the induction of buprenorphine. In one study by Cunningham and colleagues, buprenorphine was actually initiated by the pharmacist at the pharmacy before transfer of the patient to the physician's care. Administering long-acting injectable naltrexone is another potential role for collaboration of the pharmacist with the rest of the treatment team. And serving as a medication unit is an important way that the pharmacy and pharmacist can be involved. This means that the pharmacy houses the methadone that is associated with an opioid treatment program. According to the SAMHSA federal guidelines for opioid treatment programs, a certified opioid treatment program may establish a medication unit or units to administer or dispense medication therapy. And a community pharmacy location is specifically provided as an example of a medication unit that can be established. This model may be supported by the pharmacy billing for an administrative fee in addition to the medication itself. So it has the potential for financial implications for the pharmacy as well. An additional way that pharmacists can be involved in the provision of medications for opioid use disorder is by engaging in medication therapy management via a collaborative practice agreement, as first described by my friend and colleague Bethany DePaula. In her example, patients in a buprenorphine naloxone maintenance program were managed by the pharmacist using a drug therapy management model and a collaborative practice agreement. Intake assessments and follow-up appointments were conducted by the pharmacist. The pharmacist debriefed with the physician and documented each interaction, allowing for efficient assessment completion. The physician appended notes when applicable and co-signed each patient's record. The pharmacist was contracted for 6 hours per week and met with the patient for 60 minutes to obtain a detailed medical, psychiatric, and substance abuse history. The pharmacist was also responsible for reviewing clinic procedures and completing a treatment contract and providing medication adherence education with patients. Prescriptions were either written by the physician or called in by the pharmacist with physician authorization. The health department was able to save $22,000 in 12 months through this pilot program. And finally, pharmacists can be involved in the provision of medications for opioid use disorder by referring their patients to specialist care. We don't necessarily have to be involved with that specialist care or know all the ins and outs of that specialist care, but we can know where to direct our patient. I've included a link on this slide that helps to locate treatment provision programs around the country that can serve as a resource for any pharmacist who may wish to provide information about next levels of care, next steps in care, and accessing medications for opioid use disorder. Thus far, we have defined harm reduction and medications for opioid use disorder, and we've discussed some of the specifics of medications for opioid use disorder treatment as a public health harm reduction approach amongst people who have an opioid use disorder. So now we're going to zero in on some other aspects of harm reduction and strategies used to reduce harms, specifically amongst people who inject drugs. A reminder from the beginning of the presentation, about 7 million people in the United States injected drugs in the past year. 30 to 40% of people who inject drugs will die within an 8-year period. Some additional important statistics include that 30% of HIV infections in the United States occur among people who inject drugs. Further, 67% of cases of hepatitis C occur among people who inject drugs. Harm reduction approaches center on reducing risks of overdose and risks of infection, often amongst people who inject drugs, but not only amongst that population. Harm reduction approaches are supported by the World Health Organization, several UN agencies, and the US Health Department. These are some of the basic principles associated with harm reduction. They include things like accepting that many people use legal and illicit drugs, knowing there are real and tragic harms and dangers associated with drug use, acknowledging that some methods of using drugs are clearly safer than others, recognizing that many forms of discrimination and social inequalities affect an individual's vulnerability to and capacity for reducing drug-related harms, using non-judgmental, non-coercive approaches in providing services, affirming individuals are their own primary agents of reducing the harms of their drug use, meaning that individuals that are motivated to reduce their harms are the best solution for indeed reducing their harms. And finally, empowering people who use drugs to share and support each other with strategies which meet their actual conditions of use. So rather than focusing on the often elusive goal of complete abstinence, harm reduction seems to minimize risk. Let's look at an analogy about alcohol. Someone who has consumed a few drinks of alcohol at a party, for example, is advised to have transportation provided by a designated driver. Note that the message here is not a categorical prohibition against alcohol consumption, but rather to reduce harm by focusing on not drinking and driving. We can apply that same mentality to drug use as well. So think of it as steps in the right direction rather than complete abstinence. Harm reduction is shifting the focus of the healthcare team and services, as well as communities and law enforcement, toward an emphasis on moving in the right direction rather than 100% abstinence as the current goal for people who use drugs. That doesn't mean that will always be the goal, but it's setting that as an initial goal. Emphasis also can be placed on how harm can be minimized while moving in the right direction. Harm reduction seeks to place an emphasis on planting a seed and/or drawing an individual in through expression of care so that further goals can be set down the road. Many individuals who use drugs often feel as though they are seen as no longer worthy of being cared about, and harm reduction seeks to overcome that as a barrier in accessing and engaging in treatment. Harm reduction as an approach to addressing drug use acknowledges that despite a lot of effort from a lot of people and agencies to control drug use, some people will still use drugs. It acknowledges that some of these large efforts by people and agencies don't meet people who use drugs where they're at, and don't meet needs that are important to them. Harm reduction approaches seek to reduce the negative impact of use of drugs. We who are healthcare providers may not be used to thinking this way. We're often used to treatment plans and goals that involve eradication of disease with remission of symptoms. It may be helpful to know that the evidence supporting benefits of harm reduction approaches are so strong that harm reduction approaches are now endorsed by a large number of national and international health-related organizations, as depicted on this slide. One of the most important and practical strategies of harm reduction is provision of education. Information about risk of HIV, hepatitis C, abscesses, etc., when non-sterile syringes are used is really important for people who use drugs to have. In addition, overdose prevention education and awareness is really important. Things like how to recognize the signs of overdose, how naloxone can help, what to do in the case of an overdose, demonstration of how to administer naloxone, and information about Good Samaritan laws are really important pieces of information for people who use drugs to be aware of. Those of you who've gone through 1Rx training, you're already doing this. Other information about other medications and drugs combined can be very important and potentially life-saving for people who use drugs. So providing information about the dangers of combinations of alcohol, sedatives, especially benzodiazepines, as well as other licit or illicit drugs is really important. There are some links and example resources on the next slide that may be useful in providing this information to your patients. Now, rather than stand behind the pharmacy counter or across the desk from my patient and deliver a litany of information or a lengthy monologue, I like to consider how I can make it a conversation, let's say with someone who comes into the pharmacy to ask about buying syringes. I might approach the conversation such as this. What do you already know about risk of infection when injecting something with a syringe? Do you ever worry about overdosing? Would you mind telling me about how you inject, like your technique, what you use to mix drug with? I'm wondering if there are ways to make it safer for you. Have you ever thought about getting into treatment? Tell me about that. Would you mind if I tell you some information that I've learned about overdose risks and how to prevent it? These kinds of approaches have helped me to try to meet the patient where they are, to try to avoid giving information that they are already well aware of, and to avoid sounding preachy as I try to deliver information that I think might be helpful. I want to convey an openness to meeting the patient where they are and providing resources and information that can be helpful to them, hopefully establishing a relationship that can continue going forward and in further engaging my patient in beneficial health practices. This is a screenshot of just some of the resources that are available at the website harmreduction.org. These can be printed off and shared with patients to help give them further educational information and help promote safer practices. In general, this website, harmreduction.org, is an extremely helpful collection of resources, both for patients and for myself and other healthcare providers to further enhance their understanding and practice related to harm reduction. A second practical strategy of harm reduction is referral to syringe access programs. Syringe access programs are just what they sound like. They're programs that promote access to or directly provide sterile syringes and often other injection supplies. More on that in just a few minutes. The intent of syringe access programs is to reduce the spread of blood-borne infections by providing people who inject drugs access to sterile syringes. Often, syringe access programs will offer other services as well, including other harm reduction supplies, HIV and hepatitis C virus testing, harm reduction education, drug supply testing so that people who are going to inject drugs can determine if their drug supply has been adulterated with other substances, syringe disposal services, and counseling and treatment referrals to substance use treatment or other services. Syringe access programs have often been criticized and stigmatized. This seems to stem largely out of fear that they'll lead to increased crime, increased disease transmission from discarded syringes, and increased drug use. But it turns out the evidence is much the opposite. People who inject drugs are 5 times more likely to enter a treatment program after they have visited a syringe access program. Further, they are actually more likely to reduce or abstain from injecting when they're using a syringe access program. A study out of Washington, D.C. found that once a ban on syringe access programs was lifted, 120 HIV cases related to IV drug use were prevented, which resulted in a savings of $45.6 million in treatment costs. Given the data out of the CDC that syringe access programs increase engagement in treatment, decrease overall drug use, and decrease infectious disease transmission, as described on the previous slide, it is an evidence-based harm reduction approach for all healthcare providers to refer people who inject drugs to syringe access programs. The North American Syringe Exchange Network keeps an up-to-date map of programs across the USA and the type of program that is in each location. A one-to-one program is the most restrictive type of syringe access program, and it supplies 1 syringe for every 1 discarded syringe that is brought in. A 1+ program is slightly less restrictive and will provide some predetermined number of extra syringes beyond 1-for-1. For example, these programs often provide 10 extra syringes regardless of the number of disposed syringes brought in. Even if no syringes are returned for disposal, an individual could still receive 10 new syringes. Other such programs allow for 2-for-1 exchange schemes up to a certain limit. And needs-based syringe exchange programs, as depicted on the map by the code NB, these are the least restrictive types of syringe access programs, where people who inject drugs receive as many syringes as they need without regard to the number of syringes returned. This image depicts and explains the types of materials, safe injection supplies really, that would be distributed along with syringes at a syringe access program. So the items are numbered, including a clean bottle for mixing water and bleach. Number 2, bleach to disinfect used syringes. Number 3, bandages to help avoid infection after injecting. 4, sterile water to mix the drug with. 5, a tourniquet to tie off above the injection site. 6, a bottle cap for mixing water with the drug before it's drawn up into the syringe, commonly called a cooker. 7 is cotton balls to trap dirt and debris as the drug, mixed in water, is pulled into the syringe. 8 is syringes, which often don't come inside the kit itself, but are provided at distribution sites. 9, step-by-step injection instructions that come in English and Spanish. That's the example as provided here from an injection facility outside of New York. And alcohol swabs to clean the injection site before insertion. It's important to note that these supplies are not restricted to being provided by syringe access programs. Any community pharmacy or other such healthcare institution could provide all of these supplies to promote safe injection. We have previously addressed partially the question of does harm reduction work on previous slides, but just to reiterate, harm reduction has been shown to reduce HIV and hepatitis C virus transmission. In 1990, 54% of people who injected drugs in New York City were HIV positive. By 2001, 9 years after the first legal syringe exchange program began operations, the HIV prevalence among people who inject drugs was reduced to 13%. Rates of hepatitis C infection among recent people who inject drugs, so that was within 5 years of the time that the study was conducted, those rates also declined from 71% to 38% as a result of access to sterile syringes. Harm reduction approaches also help individuals engage in treatment. They are cost-effective, They have not been shown to increase rates of community drug use, and they actually have been shown to reduce criminal activity. Watson and Hughes, in their review of pharmacists and harm reduction, found that harm reduction programs in community pharmacies do not result in a significant increase in criminal activity in the store, nor do they result in reduced clientele due to fear or discomfort. So there is a strong conclusion that yes, harm reduction does work and is an evidence-based approach to the care of people who inject drugs and people who have drug use disorders. Despite the decades of strong evidence that harm reduction works, there have been some challenges that have prevented its acceptance and widespread implementation. One of those is stigma. Stigma is defined as belief based on a person's attributes or behaviors that leads to discrimination and poor care provision. Often stigma is not something that is on the front of a person's consciousness or awareness, and it's rarely intentional. Regardless, it often still does lead to discriminatory practices and poor care provision by healthcare professionals. Some examples would be stigma from individuals. This would include things like locking up valuables if a drug user visits, calling people junkies or using other judgmental discriminatory language, believing that drug users are aggressive or seeking drugs. Now, that doesn't mean that sometimes these things aren't true, but stigma really occurs when these types of beliefs are applied to all people of a certain population. So, for example, believing that all drug users are aggressive, or every time you speak with them, they're likely to be seeking drugs. Stigma within institutions, examples of that can include creating restrictions for who's eligible for treatment or services, for example, mandatory drug testing in treatment programs or job requirements. A lack of training provided leading to unintentional lack of awareness about how to treat opioid use disorder would also be an example of an institutional stigma. Stigma within communities would include things like discriminatory laws related to group characteristics or behaviors. Research in 2016 and 2018 showed that stigma and bias can drive pharmacists, even unconsciously, to act in ways that limit or block access to syringes or other harm reduction and public health services. Sometimes it's hard to remember that people who use drugs are complex, multifaceted individuals who are more than their behaviors. They're more than their drug use. They have families. They have goals. They have feelings. They could be just like your grandmother or my uncle or my brother. It's important for us to remember that they have connections to others, that they matter in our human society, and that caring for them is still a very important part of our responsibility. And the best way to combat stigma as a barrier to the implementation of harm reduction and other evidence-based care practices is first to be aware that it is there and that it may be having an impact on the way that you practice. Let me take you through an additional example. Most states permit the non-prescription sale of syringes, but some require pharmacists to document the customer's name, address, and intended use of the needles. This can be a way for stigma to be introduced and lead to lack of provision of caring service. For an example, let's imagine a person comes into your pharmacy asking for syringes. You ask what they're for. The person says, "My grandmother's diabetes." You ask what kind of insulin she uses. The person says an insulin name or dose that doesn't make sense, so the pharmacist denies sale of the syringes. Now, many of us may think, I'm doing the right thing here. I'm preventing this person from doing something illegal. I'm carrying out my responsibility to uphold the law, and if this person is going to behave this way, at least I'm not contributing to the wrongdoing. Now, some of us may even have been trained in this kind of thought process or are under corporate policies that say something similar. And unfortunately, we are likely contributing to disease and mortality by thinking that way and behaving that way. If we really think about it, with the course of action taken by the pharmacist in this example, by denying clean syringe use, that pharmacist is actually promoting non-sterile needle use, which means spread of hepatitis and HIV and cellulitis and other problems. Would you ever in your professional life do something to promote infection in any other circumstance? Whether we agree with the person's behavior or not, can we agree that as pharmacists, we are responsible to contribute to lower risk of harm? Can we agree that if we provide syringes for this person, we may be able to develop some rapport with them? That we may be able to talk to them about opportunities to be healthier, about opportunities to get treatment, about their value as a person. If the person in the scenario were your brother or daughter or father, wouldn't you want their pharmacist to do that? Stigma can be overcome when we become aware of it and its effects on the people we marginalize as a result, and then choose not to judge, but to care. Another challenge that has impeded the widespread implementation of harm reduction practices, specifically availability and access to sterile syringes, is concerns about syringe disposal. Specifically related to pharmacists, pharmacists have voiced concerns about disposal of used syringes around the pharmacy environment, contributing to the appearance of dirtiness and transmission risk. These actually appear to be quite unfounded. Interestingly, pharmacies that have engaged in safe syringe distribution have not found increases in syringes being improperly disposed. And pharmacists that have concerns about improper syringe disposal can combat that head on by providing personal disposal boxes, distributing clean syringes using referral cards, referring patients to syringe access programs, and providing information about safe syringe disposal, including an FDA resource that is listed, or resources that are listed at the links for you. As I've previously alluded to, there are many ways that the pharmacist can become involved with harm reduction approaches and practices. But first, let me read you a quote from Robin Polini, PhD and MPH from the Pacific Institute for Research and Evaluation. Pharmacists are in a very challenging position when it comes to illicit drug use. On one hand, law enforcement asks them to play an active role in preventing the diversion of prescription opioids and other drugs of abuse. On the other hand, my colleagues and I in public health ask them to help us stem the HIV and hepatitis C virus epidemics by expanding syringe access for people who are using illicit drugs. I want to acknowledge that this is not an easy dynamic for pharmacists to navigate. Ultimately, we have to use our professional judgment and evidence to guide our course with each patient and with programs and practices that we choose to implement. Providing clean needles or syringes is one of those possible practices and approaches that could be implemented. Offering clean needles at chain or supermarket and independent pharmacies allows the greatest potential to reduce harm because these businesses are convenient and open for much longer hours than many traditional places that could be accessed by people who inject drugs. Studies have shown that current or former injection drug users actually perceive less stigma from pharmacists who dispense syringes compared with those who do not. Pharmacists could also refer to syringe exchange programs if they're not offering clean syringes right at their specific locale. Furthermore, pharmacists can offer syringe disposal so that those syringes that have been used are safely disposed of and do not present risk for transmission or promote an appearance of a place that is an unsafe environment. Pharmacists can engage in hepatitis C and HIV screening. Numerous CLIA-waived point-of-care and home use tests are available for HIV, HCV, and sexually transmitted infections testing. Some are available over the counter, and others for use by health professionals only. Interested pharmacists could educate customers about point-of-care testing, as well as actually providing testing and counseling on results. Several recent publications describe the benefits, barriers, and role of pharmacists offering testing services in their communities. Finally, pharmacists can become involved in skin soft tissue infection and wound care over-the-counter management. Pharmacists are in a position professionally and logistically in their community to be a resource for wound care management. As people who inject drugs have an increased risk of skin and soft tissue infections and damage to veins and muscle tissue, pharmacists may wish to extend their expertise to people who inject drugs. OTC wound care products are available in pharmacies, and pharmacists have the expertise to recommend self-management and recognize when a referral for more extensive medical care is needed. Our objectives for this presentation were to define medications for opioid use disorder and harm reduction, identify examples and standards of care in medications for opioid use disorder treatment and harm reduction practices, identify harm reduction challenges and resources, and list ways that pharmacists can participate in medications for opioid use disorder treatment and harm reduction practices. I want to call your attention to several free resources that can help you to expand your knowledge and practice confidence with regard to implementing many of these things. Finally, I want to conclude this presentation with an image of 4 common myths about harm reduction, followed by the data and facts that indicate that indeed these are myths. These can help to promote discussion and challenge misconceptions amongst our colleagues, our patients, our communities, and even within ourselves. Before turning off this presentation and completing the process to obtain your continuing education credit, perhaps you can take a moment to self-examine your own perceptions about people who use drugs and harm reduction. What do you find there? Are you happy with how those findings and perceptions contribute to well-being of the patients you care for? I hope so. If you're not, though, I hope this presentation and the resources herein can be of help in taking a next step. I invite you to reach out to me as well. You'll be able to find my contact information on the OneRx website, and I am happy to have further conversation with anybody who may be interested. Thank you.